Here we go again. So this lecture is on chapter 36, and this is Pharmacology, Antianginal, and Vasodilating Drugs. So what do we need to know about these things? Let's go over some key terms first. So words that you must know. Atherosclerosis. So what that is, it's fatty plaque that deposits inside of arteries that makes the lumen of the artery smaller and makes it harder for the blood to get through. Arteriosclerosis is a hardening or stiffening of the arteries, and that comes typically with age. And angina. The word angina is chest pain. Okay, that's usually due to not enough oxygenated blood getting to the myocardium or the heart muscle. Okay, so the must know meds. You got two for this chapter. And the first one, I'm going to give you everything you wanted to know about nitroglycerin, but we're afraid to ask. Nitroglycerin is a nitrate. And what it does is it relaxes and opens up all the blood vessels in the body, vasodilation. That increases oxygenated blood flow to your organs and your brain and your myocardium, your heart muscle, okay? And there are lots of different forms of nitro. So I'm gonna go over all of this right off the bat. So pay attention, this is important. So you've got rapid acting nitroglycerin, which is sublingual or buccal. Sublingual are little tablets. They usually come in a little brown glass bottle. Sublingual means under the tongue. And then buccal usually comes in the form of a little spray, and it's sprayed into the oral mucosal inside the cheek, okay? And so with the onset of angina, chest pain, the patient is instructed to either take one tab under the tongue, sublingually, every 5 minutes up to 3 doses. If there's no relief after the first dose, the patient must call 911. Not their daughter, not their aunt, or their neighbor down the street, because none of those people have ACLS, and paramedics do. Because if the patient really is having an MI, a heart attack, then they can intervene quickly and save that person's life. So they can still take their other 2 doses, but they need to call 911 if there is no relief after the first dose. With those sublingual tablets, a couple things to know. If their mouth is dry, they should moisten their mouth with a sip of water or maybe suck on an ice cube or something to get their mouth moistened so the tablet will dissolve under their tongue. If they tell you, oh, my tongue's tingling, you tell them, great, that means it's working. Okay, not a problem. That's a normal, expected effect. One of the biggest side effects, headache, because of the vasodilation. Have you ever stood on your head or been on an upside down roller coaster? So when that happens and all the blood rushes to your head really quickly, you can get a headache. And so a headache is a very common expected side effect of nitro, the rapid acting nitro, the buccal spray or the sublingual. And over time, they usually will start to go away. In other words, if the patient uses the nitro more than one time, they won't get the headaches as badly, but they can always take a good old Tylenol, acetaminophen, to help relieve the headache pain. And then the other thing they may feel when, as the tablet starts to work, they'll feel this feeling of flushing. Again, all their blood vessels are relaxed and wide open, so all this oxygenated blood is flowing through their body. That is an expected side effect. You want to make sure that they know to change positions slowly, because with the dilation of all the blood vessels, blood pressure will drop. And so if they go to move quickly to stand up, they're going to fall over. They should always store in a cool, dry place. The reason that the tablets come in a little brown bottle is to protect the tablets from ultraviolet light. So they should never be, stored somewhere where, like on a kitchen counter or a windowsill, where the sun will hit them, because they will become deactivated. Okay, and they must replace their prescription for that sublingual nitro or that buccal nitro every 6 months. And then prophylactic use. I just want to go over this quickly. If you have a patient who does suffer from angina occasionally, but only with exertion. So example, your 88-year-old patient who says, well, I don't usually get chest pain, but when I have to vacuum, then sometimes I do. Well, they can take one sublingual nitro or one buccal spray about 15 minutes or so before the activity. That's prophylactically, preventatively, to help increase the blood flow, and then maybe they won't get that angina when they're doing their chore, they're vacuuming or whatever it is they're doing. Okay, so that's the sublingual and the buccal spray, rapid acting. The next one is the transdermal patch. So the patch is a little patch and it's self-adhesive. You peel the layer off and it gets stuck on the anterior chest wall, right? Anterior chest wall, best place for it. It's on for 8 to 12 hours daily. It should come off at night. You should always try to choose a hairless area if possible, but never, ever shave hair, okay? You must always put your initials and the date and the time that you place the patch on. So this way, you know, if there's another nurse coming behind you, that nurse will know when it went on, so they'll know when it needs to come off. Always rotate sites, because what can happen if we keep using the same site over and over again, and this holds true for any transdermal patch. You keep using the same site, the site is going to become irritated over time, so you're going to rotate sites. Always wear gloves when you're dealing with patches, because you don't need nitro, you don't need fentanyl, right? So make sure you wear gloves. And when you're removing the old patch, when it's removed, you fold it into itself to dispose of it, so that the medication side of it that was touching the skin is not exposed, okay? And that's important to remember. Then there's nitro paste. Nitro paste comes in a tube, kind of looks like a toothpaste tube. And it also comes with these wax paper-like applicator papers. And the papers have markings on them that are in increments of inches. Use one of those paper applicators per application. It's the same kind of premise as the transdermal patch. It goes on in the morning, comes off at night. So you take the tube and the script will read, apply 1 inch of nitro paste daily. And so you'll squeeze the tube onto that paper applicator strip to 1 inch, place it on the anterior chest wall, and then place a clear occlusive dressing over it, like a Tegaderm, okay? So it stays on, okay? Those wax paper applicators don't have any kind of adhesive on them, okay? And the same premise, you should always put your initials and the date and time that you placed it there. Make sure that when you remove the old one, that you're cleansing that area. You can use normal saline, you can even just use soap and water, okay, to prevent irritation of the area, and rotate the sites also to prevent irritation, okay? So with nitrates, they're going to dilate blood vessels, okay? They increase blood flow, perfusion. They increase oxygenated blood flow, that is perfusion, to your brain and your skin and your tissues and your organs and your heart muscle, your myocardium, okay? They're used for acute anginal attacks. They can be used prophylactically to prevent an anginal attack. And they're also used as sometimes the long-acting. There's a sustained release oral that is used and to treat, you know, recurrent angina or hypertension, okay? Now, I've already talked about the side effects as far as the headache. That's the one, right? Dizziness, weakness, body flushing, all those things. I'm not even going to go into this, but if the patient has a hypersensitivity to the drug, and this holds true for every drug, don't give it to them, okay? And you want to be very cautious in using this drug. Patients with severe hepatic, liver, or renal, kidney disease, and anybody with head trauma, because it can actually increase the possibility of an intracerebral hemorrhage. Think about it, it's increasing blood flow, right? That makes sense, doesn't it? They should not be drinking alcohol with this drug. They can have severe hypotension and cardiovascular collapse, and they should not be on heparin and using nitro, because they will have a decreased effect of the anticoagulant properties of the heparin when it's used with nitro. And that's nitro. Drop the mic. The next one we're going to talk about are calcium channel blockers. And so that's an anti-anginal drug pretty much as well. It's used for anginal pain with different types. There are lots of different forms of angina. I'm not going to get into all of that, but you know, if they have vasospastic or chronic stable angina, in other words, they're not at risk so much for a heart attack, but they do have this recurrent angina. We can give them calcium channel blockers, which, by the way, will lower their blood pressure as well. Okay. So, what do you need to know about calcium channel blockers? The one I need you to know about is amlodipine. It's also known as Norvasc. Okay. It slows the heart rate down. Okay. It dilates the coronary arteries. But unlike DIG increases the contractility of the heart muscle. Calcium channel blockers decrease the contractility of the heart muscle. So they make the heart muscle not so elastic. Don't worry about the calcium ions across the cell membranes. No one's going to ask you about that, okay? But just understand that they do slow the heart rate down, okay? As far as reactions, side effects, those kinds of things, dizziness, lightheadedness, headache, kind of the same, right? They can have something called asthenia, which is a loss of muscle strength, fatigue. They can develop peripheral edema and even arrhythmias and severe bradycardia. Okay, so that's what I want you to know about the calcium channel blockers. There are some precautions in when you should use them or not use them, or use them judiciously or cautiously. If patients have heart failure or renal problems or liver problems, or if they're pregnant, or if they are lactating, breastfeeding, you want to find another drug to use, okay? And as far as interactions, a couple that are important for you to know is that with calcium channel blockers, if they're used with theophylline, remember that was a respiratory drug, theo? Calcium channel blockers will make the effect of theo toxic. So they shouldn't be used together. And also, you shouldn't be using calcium channel blockers with digoxin, because they are at increased risk for dig toxicity. And that is important for you to know. As far as pre-administration assessment, the same basic things. You know, you're always checking vital signs, heart rate, blood pressure. You're doing blood pressures lying, sitting, and standing, checking for orthostasis. You're going to make sure that you're documenting. You know, how often is the patient having these episodes of angina? Are they related to activity or unrelated to activity? And with the calcium channel blockers, remember, congestive heart failure. You're always going to be checking for signs of CHF, because that's one of the things that calcium channel blockers, just like the beta blockers, can do that too, right? Cause heart failure. You're looking for shortness of breath, a new onset of shortness of breath. Weight gain, peripheral edema, so feet, ankles, lower extremities are swelling. Any sounds in the lungs like crackles, because that's a sound, that's a sign of fluid. Oh, and jugular vein distension, which is also a sign of fluid retention. Make sure that you tell the patient that they, always a risk of hypotension and lightheadedness. Move slowly, change positions slowly. And, that's pretty much everything that you need to know about these drugs. And that is the end of this chapter. Make sure that you understand nitro, everything that I said about nitro, okay? And one more thing. At the end of this PowerPoint, there's questions and answers, some review questions. The last one on page or slide 36 is asking about men that take antianginals. Should they be assessed for erectile dysfunction? Okay, because men that are on antianginals or vasodilators cannot receive Viagra, sildenafil, because it can cause priapism, number one, which is an erection that lasts more than 4 hours. And then it can also cause such vasodilation that they'll have an erection that won't go down, but their blood pressure will be down in the toilet to the point where they won't be able to get up. Even sometimes they can go unconscious. So these are the groups of drugs that men cannot take an erectile dysfunction medication with. But if you go back to chapter 35, they can with some of those other drugs like the ACE inhibitors and the ARBs. Okay? All right. So you know where to find me if you have questions. I hope this was helpful, and we're going to be moving on to anticoagulants next. And see you. Bye-bye for now.